This lecture was put together in 2006. I was asked by one of the chief residents to give a talk on basically what is the physiatrist's role when seeing people with osteoporosis and really vertebral compression fractures. So there's some discussion of anatomy, pathophysiology, talking about bone. I think it's a great topic. It is limited to the research and literature that was available in 2006. So take it for what it is. So this lecture is basically, again, going to talk about what our role is. I will cover all the usual players: epidemiology, cost, risk factors. We'll do a little bit of radiology, a little bit of acute management. I think you're going to like that, where we talk about the physical therapy prescription, the evidence for exercise, and other types of management. So unless otherwise, unless there's a trauma involved, compression fractures are the hallmark of probably underlying osteoporosis. So it's important that if you do see a compression fracture, you want to look for causes and then offer them comprehensive treatment. Even though we're going to be focusing on the vertebral compression fractures, osteoporotic fractures can occur pretty much anywhere. The hip, I think, is the scariest because that's associated with a higher mortality. You will see wrist, and today's focus again is going to be on the vertebral compression fractures. I think there's been a lot of controversy about the management. In 1944, Dr. Watson Jones said that perfect recovery is only possible if perfect reduction is insisted upon. But his compatriot Nicole asserted 5 years later that marked deformity is compatible with perfect function. So since that time, the pendulum just keeps continuing to swing between the two extremes of whether you have to fully address deformity or not. There's probably been less funding and less research that's gone into looking into non-pharmacological treatment of osteoporosis. And so that's why, the literature on what we do is probably less than it could be. So the role of the physiatrist, if you have been wondering, is that it's pretty clear that only pharmacological management is not enough to address the bone mass issues and the fractures issues. We can play a key role after fracture, and we can prevent other fractures. We can offer the main treatment of muscle re-education and resistance exercises, and we can help with reducing kyphosis. These are the key elements that we can address, and also prevent falls so that they don't have other fractures. We should be part of global programs for prevention and management. We can reduce costs and morbidity, and also we can improve mobility and prevent death. So the epidemiology, not really totally well understood, because is it a morphometric definition of a vertebral compression fracture, meaning you could see it and someone could be asymptomatic? So do we take those people into consideration or not? But the numbers are, back in 2006, 25% of all postmenopausal women in the US, 40% of women age 80 and above, 15% higher mortality with than without. The incidence kept increasing. I think the aging population contributed to that. And only 35% of new fractures are actually painful, so maybe we're missing them. It's costly. You can break down the risk factors into modifiable and non-modifiable. The modifiable risk factors are laid out here. I think we can address, we can actually educate them about these. but I think the insufficient physical activity becomes more and more of an issue, and we can help with that in a more directed way. Non-modifiable risk factors, we already mentioned how advanced age, female gender, turns out Caucasian race, presence of dementia, and if you are susceptible to falls, more fractures. So let's go over other vertebral body fractures before we go into the compression fracture. So you can either have a split fracture or a burst fracture. The burst fracture is basically the whole vertebral body as shown in this picture, and it can lead to a comminuted fracture. And the split fracture is shown, picture's worth 1,000 words. The wedge fracture is the one that's most commonly seen with osteoporotic compression fractures. So let me remind you of the Denis classification of 3 columns where you have an anterior, middle, and posterior column. And if there's any issue with the middle column, or if there's any issue with 2 columns, then you have instability of the because of the fracture. So if you don't have instability, usually with the wedge fractures you don't have instability and you lose height anteriorly while the posterior is unchanged, and that's what gives it that wedge look. So presentation is variable. Main thing is that only about 1/3 are actually diagnosed because only about 1/3 are symptomatic. And many patients and families regard back pain symptoms as arthritis or a normal part of aging. Therefore, compression fracture should be suspected in any patient older than 50 years with acute onset of sudden low back pain. Most patients will remember a specific injury as the cause. However, fractures can occur without any history of increased force on the spine. Lying in the supine position generally relieves some of the discomfort, while standing or walking exacerbates the pain. And the pain is thought to be due to irritation of the periosteum. It tends to be self-limited in most cases. So if we look here, actually going to go up here. So with a healthy spine, you need a pretty significant impact, such as a motor vehicle accident or a hard fall. With moderate osteoporosis, tripping, falling from a chair, even lifting a heavy object, or raising a window might do it. But with severe osteoporosis, it happens during routine activities of daily living. Could be after stepping out of a bathtub, even a vigorous sneeze, lifting a trivial object. It's the load caused by just muscle contracting, coughing or sneezing. So it depends on what the underlying osteoporosis is. On physical exam, you'll probably see tenderness directly over the area of the acute fracture, and an increased kyphosis could be noted. In cases of uncomplicated compression fractures, a straight leg raise should be negative and neuro exam should be normal. If they have an ileus, you might have decreased bowel sounds, and the spine is tender, and the paraspinal vertebral muscles spasms are often present as well. So should we do X-rays before treatment? I would say yes. Usually we said it was an insidious, 2/3 go undiagnosed and are found as an incidental finding. This image is from a case study that was published of a 66-year-old woman with osteoporosis and thoracic kyphosis who'd been receiving alendronate for 8 years. And her chief complaint was stooped posture that was getting worse. She had frequent chiropractic adjustments for occasional back pain, but she was pain-free at the time of her evaluation at the institution that published this. Neurologic exam was normal. Lumbar spine radiographs were negative, but no thoracic spine radiographs had been obtained before her referral. And, it just goes to show that you can be on pharmacological treatment and known to have vitamin D and calcium issues, but still people are not being imaged and being left undiagnosed, which means that you can't help prevent future fractures and worsening kyphosis. So for imaging, plain frontal and lateral radiographs are usually the initial imaging study obtained for a suspected compression fracture. Compression of the anterior aspect of the vertebra results in the classic wedge-shaped vertebral body with narrowing of the anterior portion. Radiographically, a decrease in vertebral height of 20% or more, or a decrease of at least 4 millimeters compared with baseline height, is considered positive for a compression fracture. They can occur anywhere from the occiput to the sacrum, although they usually occur at the lumbodorsal junction, namely T8 through T12, L1, and L4. It's important to image the entire spine because 20 to 30% of vertebral compression fractures are multiple. When multiple, the fractures occur at different levels or in 1 to 5 consecutive vertebral bodies. So serial plain films may be necessary to visualize the vertebral injury because the deformity can take days to weeks to develop. CT scans and MRIs are used to evaluate posterior vertebral wall integrity and for ruling out other causes of back pain. CT can be helpful in identifying a fracture that's not well visualized on plain films, for distinguishing a compression fracture from a burst fracture, and for further evaluation of a complex fracture. CT can also reveal spinal canal narrowing. MRI is what you would use if you were looking for neurologic symptoms. Malignancy, not osteoporosis, should be considered as the cause in patients younger than 55 years with a compression fracture without trauma or even minimal trauma. In these patients, or in those known with suspected malignancy, you should probably look at MRI as part of the workup. There's a fluid sign, which is presence of a fat fluid level on MRI, which can be useful to distinguish osteoporosis from malignancy as the cause for pathological fracture. MRI also allows for the differentiation of edema caused by benign fracture from that of tumor infiltration. You can also look at the bone marrow, follow-up films. Imaging is quite important in the context of osteoporosis, osteoporotic compression fractures. Bone scan can be useful for surveying the entire skeleton, especially when you're considering they may have sacral insufficiency fractures, stress fractures. You can see the H or butterfly pattern across the sacrum, and it can distinguish between old and new. Determining stability or instability of the fracture is probably the most important first step. A stable fracture won't be displaced by physiological forces or movement, and if it's unstable, it could lead to all sorts of neurologic compromise, which we don't want. So there are complications from compression fractures of the spine that you would be surprised by. The things like constipation, bowel obstruction, ileus, compromise of respiratory excursion, psychological effects, and then you've got the things that are kind of not so surprising, like you could get a radiculopathy along with it because of irritation of the nerve root. You could have, and that would kind of present along the rib. You could get cord compression, but that's extremely rare. And you can also have, continued pain and worsening kyphosis. It's also a risk factor for further fractures. So let's look at how to treat it. I break it down basically in the acute pain, then the chronic pain, and then the preventive measures that we can do. And most patients are going to make a full recovery or at least significant improvement from their compression fracture overall after 6 to 12 weeks and can return to normal exercise programs after the fracture is fully healed. So the main objective of physical management is to eliminate pain-induced reflex inhibition. Spinal compression fractures and pain can produce an imbalance between the use of the back extensors, which is the major trunk supportive muscles, and the flexors. And the pain-induced inhibition results in overuse of spinal flexors, and that'll further contribute to the kyphosis. So that's why it's necessary to relieve pain through reduction of edema in the soft tissue surrounding the fractured area. And that reflex inhibition will then therefore be affected. The vertebral compression fractures can stimulate nociceptors directly by structural damage, or direct compression of tissue, or indirectly by release of chemical mediators associated with tissue injury and local bleeding. And that reflex paravertebral muscle spasm that follows it's thought to be a protective mechanism like guarding, but it also causes significant discomfort. So the goals are to relieve pain through reduction in edema of soft tissue surrounding the fracture, unload the anterior vertebra by extension moment, and facilitate mobilization as soon as possible so that they don't develop maladaptive compensatory deconditioning. So the acute pain usually improves in the first month, self-limited, but we can use meds, modalities. We try to take them initially from bed rest, which definitely should not exceed 10 days. Gradually mobilize them and get them active. You can use orthotics, assistive devices, and exercises. So let's go into each of these in depth. So for medications, you can initially use muscle relaxants, which would address the reactive spine guarding that we were talking about. There's some reasoning there to use the NSAIDs based on the inflammation that we talked about. So back in 2006, narcotics were probably offered a little bit more than they would be now. But even then, we used to worry about, in the elderly population, having altered mental status, respiratory suppression, and of course, constipation. Calcitonin was encouraged at that time. Can we use modalities? Absolutely. I think ice is probably the most common. Use of a cold pack for about 20 minutes, 3 times a day. You could use gentle massage to the paraspinal muscles or muscle relaxants to decrease the pain from the muscle spasm. And some patients do prefer superficial heat, like a heating pad or a local hot shower application. It doesn't make as much medical sense, but if it feels better, it might get them mobilized quicker. A TENS unit as well if they're comfortable using that. So the problem with bed rest is that it can lead to further deconditioning and pain. So 3 to 4 days is probably reasonable in an acute situation, but the deconditioning will lead to further osteoporosis. Recommend a firm mattress with soft covering. Let them know that supine will probably feel better. Yes, you could put the pillow under the head and knees, but they should also learn how to stretch so that they don't develop contractures. Side lying with a pillow between the knees is totally fine. Prone lying with a pillow under the abdomen is great if they can tolerate it. And teaching them bed mobility exercises would be optimal. So how can we involve a therapist? There's plenty of things occupational and physical therapists can do. They can assess the patient's safety in the home and in the community. They can provide instruction in safe ambulation and transfers, and they can assess the need for adaptive equipment in the home. They should be instructed to avoid heavy lifting and bending, and they should be taught to carry objects close to the body. If there is a work issue there, then work simplification, use of rubber bottom shoes to prevent falls, and use of proper body mechanics can help prevent new fractures. So this slide is pretty heavy, and it's all stuff that doesn't involve invasive procedures or medications. So patients with acute vertebral compression fractures should be gradually mobilized, often with the use of a cane or a walker to reduce spinal weight bearing. Use of a cane in the hand, contralateral to the painful unilateral back pain, referred to the buttock or hip, may help decrease the pain resulting from weight bearing. You may need a wheeled walker that decreases stress on the spine that can result from lifting a standard walker. And walkers tend to be more supportive than canes and can be used at home or in the community. So orthoses are going to be discussed a little bit more. We're going to use them to help promote spine extension rather than kyphosis. and it prevents further immobility through support. But they're not always immobilizing, and deformity can recur. You can develop a secondary atrophy as you would with any orthosis, and also they're uncomfortable. So the reason to use them is reduction of motion of joints, reduction of ligament stretch, and reduction of flexion, and that results in support of the spine and decreases pain. It might reduce overguarding and all that secondary muscle tightness. It can give a kinesthetic feedback, and it can just be nice and comfortable with pressure and warmth. If it helps you decrease time of immobility, that's great, but we want to get rid of it as soon as possible to avoid atrophy. Compression fractures occur most often at the mid-thoracic and upper lumbar spine, followed by the lower thoracic and lower lumbar spine, and it's rarely in the upper thoracic spine. To decrease painful contractions of the erector spinae muscles, you need to decrease the load over the anterior aspect of the spinal column and vertebral bodies through use of an orthosis. And so we have a few options. The rigid thoracolumbar orthoses will kind of put something in front of you and prevent you from flexing, and those are the Jewett and the CASH. Now, the bivalved body jackets that you often see after trauma, I don't think anyone uses those anymore, but they could be used. And then you can also use thoracolumbar supports with rigid stays. And then we're going to talk about something called a posture training support, or kyphoorthosis, which is probably something you haven't seen before. So very board relevant, you need to know about the Jewett, which is on the left, and the CASH, which is the cruciform anterior spinal hyperextension brace. So the problem is, I think the CASH is typically used for women who have pendulous breasts because it goes over here. The Jewett could be more uncomfortable for them. So basically your orthotist should be measuring and trying these out on the patient to see which one they prefer. And as you can see, it tries to prevent hyperflexion, but it's not going to, it'll promote extension, but if the patient is pushing through it, it may be very, very uncomfortable. So this is called a flexible kyphoorthosis. And basically it's like a backpack. It's got some weight in the back. And because of that weight, it's been shown to promote extension more than the other ones. The other ones kind of prevent flexion, whereas this actually promotes extension and reduces kyphosis. I'll show you another slide on this later. So we were talking about acute pain, and we've gone through modalities, meds, therapy, and orthotics. Now, how about exercise? This is great because we can restore pain-free range of motion by and that'll decrease pain-related paraspinal muscle co-contraction. Initially, you're going to see that they really can't tolerate anything more than isometric contractions. So avoid heavy resistance strengthening, maybe in the first 2 months, but I think this is more of an individualized decision. Spinal compression fractures can be insidious and can produce only modest back pain early in the course of progressive disease. But over time, multiple fractures can result in significant loss of height. Progressive loss of stature results in shortening of paraspinal muscles, requiring prolonged active contraction for maintenance of posture. And this can result in pain from muscle fatigue. The pain can continue long after the acute fracture has developed, and they start to develop thoracic kyphosis and lumbar lordosis as vertebral height is lost. And the rib cage starts pressing down on the pelvis, reducing thoracic and abdominal space. In severe cases, this results in impaired pulmonary function, a protuberant abdomen, and because of compressed abdominal organs, they'll have early satiety and weight loss. So now we can talk about the chronic pain. Usually this is of lesser intensity. It can radiate laterally, It's exacerbated by exertion and relieved by rest. There can be a high incidence of arthritis along with it. They may benefit from kyphoorthosis, posture management, and we're going to go into all of these now. The chronic part, we talked about how everything starts to compress. Well, there's something called Iliocostal friction syndrome. This is a condition caused by friction of the lower ribs against the iliac crest, which leads to irritation of soft tissues. It's characterized by undiagnosed chronic side pain. The distance between the lower ribs and the iliac crest is normally sufficient to prevent contact between the two, even when bending to the side. But in the iliocostal friction syndrome, friction and damage to the tendons and muscles that insert at the iliac crest and the lower rib cage, especially when bending to the side, occurs. So the treatments that have been described for it are to use that postural support like I had told you about before. You can try and use a wide, soft belt. People have tried injections into the iliac crest margins with lidocaine and prolotherapy and had some good results. And then you can also do a lower rib resection. I think the main thing is identifying it and then, not chasing all sorts of treatments that aren't going to help it. So in the context of osteoporosis, I think it's important to talk about what happens with aging. Sarcopenia is one component. That's basically weaker and smaller muscles. You lose type 2 fibers, and then you get more type 1 irrelevant in comparison to the type 2. You get a decreased protective role of the muscles as a result. And then we can talk about osteopenia, and this leads to an imbalance in musculoskeletal stability. You get decreased biomechanical competence. Sudden gonadal atrophy at menopause leads to an exponential decrease in bone mineral density. You lose disc resiliency as you decrease the number and diameter of collagen fibrils. You get less paraspinal muscle strength because of progressive weakening. And then gravity has a tendency to, push us forward like this and down. So that also contributes to kyphosis. And let's not pretend osteoporosis is a misogynistic disease. It starts to hit people, women earlier in their lives, and they have faster and more bone loss over their lifetime than men. So posture, balance, locomotion, all of these depend on joint proprioception. There are receptors in muscles, tendons, joints, ligaments, and skin, and they all play a role in proprioceptive input. So joint position sense is fundamental to posture, balance, and locomotion. Post-fracture pain, induced reflex inhibition, and vertebral deformity, these can interfere with the kinesiology of the spine and proper recruitment of paraspinal muscles for support of the spine. Therefore, muscle re-education through biofeedback techniques is very important to improve synchronized muscle contraction during movement of functional units of the spine. So in a controlled, randomized trial using electrical stimulation to the lumbar paraspinal muscles, back muscle strength improved extensively at 3 months. And then there was a randomized controlled trial looking at the effect of such a program plus bracing, and this improved extensor strength compared to 3 groups of women with osteoporosis who performed just back extension exercises. So another study showed a 55.5% improvement in the computerized balance test scores in subjects who used a proprioceptive dynamic posture training program at the T10 level of the spine, and continuation of deterioration of balance in those who perform back extensor exercises only. So this definitely is something to consider in your treatment. Even in healthy people, as we get older, predisposition to falls increases with age-related proprioceptive changes. Postural stability and balance performance decreases with age. A 1990 study on balance and performance and showed the incidence of loss of balance in 214 healthy subjects aged 7 to 81 years. The majority of falls during computerized balance testing occurred in subjects older than 50 years. Further, the amount of body sway increased with age. Therefore, measures that can decrease body sway can decrease the risk of falls. In a study of PDP, which I showed you earlier, balance improved with enhancement of postural proprioception and with reduced hip strategy. In normal balance, ankle strategies are recruited rather than hip strategies. Strengthening of the lower extremity muscles reduces the risk of falls, which is, it seems to make sense, but people don't address it in the normal population. Strengthening, one study showed that kyphotic posture in persons with osteoporosis contributed to the risk of falls. Another study showed that reducing kyphosis through proprioceptive training can reduce the risk of falls. So preliminary results of ongoing studies incorporating the use of Kypho-Orthoses and PDP for decreasing the risk of falls have all been promising, and gait aids and Tai Chi have been also shown to decrease the risk of falls if the patient is receptive to using them and is diligent in their use. It's a good time to talk about pathophysiology, and mechanical loading is an important component of treating osteoporosis. Normal bone can withstand strain, and it's a normal function of normal bone mass and normal bony architecture. So it should be able to tolerate the loads that we put on the body normally. But when you have osteoporosis, despite normal architecture, this leads to a situation where it can't tolerate mechanical loads, and then that can lead to fractures. So it's important to kind of game that system and use mechanical loading to actually increase bone density. So let's just look at the difference between cortical bone and trabecular bone. Cortical bone is the compact bone that we find in the limbs. It represents nearly 80% of the skeletal mass. It usually forms a protective outer shell around every bone in the body. It has a slow turnover rate and a high resistance to bending and torsion. It provides strength where bending would be undesirable, as in the middle of long bones. And if we look a little bit closer at this kind of bone, we see in the cross-section of cortical bone a series of adjacent and overlapping bullseye formations. These are your osteons or haversion systems. Each osteon is composed of a central vascular channel surrounded by a kind of tunnel called the haversion canal. And the canal can contain capillaries and vessels and nerves and maybe even lymphatics. And between each osteon are the interstitial lamellae, which are the concentric circles of mineralized bone. Lamellar bone gets its strength from its plywood-like construction, in that it's parallel layers of bone alternating in orientation by 90 degrees. Trabecular bone, also known as the cancellous bone, that's only about 20% of the skeletal mass, but 80% of the bone's surface. Trabecular bone is less dense, more elastic, and has a higher turnover rate than cortical bone. It's found in the epiphyseal and metaphyseal regions of long bones and throughout the interior of the short bones. And it constitutes most of the bone tissue of the axial skeleton. These are the bones of the skull and the spine. It has an intricate structural mesh. It's also, by the way, in the ribs. The interior scaffolding maintains the bone's shape despite compressive forces. It is rigid, but it kind of looks spongy, as you can see here. And it's composed of bundles of short and parallel strands of bone fused together. Maybe a little cooler picture would be the next slide. Here we can see normal trabecular bone on the left, and as it gets osteoporotic, you can see on the right in these scanning electromicrographs. So these laws, Wolff's law especially, are very well known among rehabilitation experts. Wolff's law basically says that bone in a healthy person or animal will adapt to the loads it's placed under. If loading on a particular bone increases, then the bone will remodel itself over time to become stronger to resist that sort of loading. The converse is true as well. If the loading on a bone decreases, the bone will be adapted and become weaker. And this is just a theme, a variation on a theme that we see throughout the body with deconditioning, where if you take the loads off of muscles, then the metabolic demand that's on it determines how much of the architecture and machinery is going to be maintained, because the body likes to conserve. There are other laws or theories. For example, Frost's theory says that you do need a minimum threshold of loading in order to increase bone density. And then Lanyon's law was that you have the greatest osteogenic effect when the exercise or the loads are vigorous enough to produce high strain, repeated daily, short in duration, and applied to specific bone sites. So a majority of what we know about exercise in osteoporosis, or at least the rehabilitation of osteoporosis, comes from Dr. Marshid Sinaki's research, as well as she's the one who did the chapters in all of our textbooks. And she always starts by saying it doesn't really matter how old they are, you should start treating them for prevention right away with exercise. So obviously address their diet and supplementation, smoking cessation, medications. Make sure, this can be something you make sure someone else does, or you can do this on your own. And then the general components initially of a program for prevention would be back extension strengthening, which decreases thoracic kyphosis and addresses the posture. In fact, you try to avoid any kind of flexion, so it's an extension-based program, unless you're specifically dealing with someone who wants to do a lot of golfing or bowling. You can start with isometric abdominal muscle strengthening and then progress to other kinds of abdominal strengthening. And this will also help with the lordosis and the protruded abdomen. These can be difficult to maintain, and you know what? It might actually be better to do a high-intensity, short-term program than it is to try and do a long-term program, because they have poor compliance. So an osteogenic fitness program is one where you're prescribing exercise to try and increase bone mineral density, improve the architecture, increase strength. For normal bone mineral density, high-impact exercises such as aerobic jogging and skiing, these are good, as well as anything that's going to be weight-bearing. For osteoporotic bone mineral densities, non-strenuous, low-resistance exercises can be started with, and then you can advance to anti-gravity strengthening as tolerated. And you want to encourage them to maintain a reciprocal arm swing while walking, and that helps loosen the paraspinal muscles. Other exercises that can be considered, any kind of axial loading during lifting at the job or caring for children can actually be as osteogenic as working out in a gym. Aerobic conditioning is not as osteogenic, but if it is like fast walking, that'd be great. Swimming has also been shown to increase bone mineral density, but only in men. Bicycling, as long as your posture is maintained and you avoid spinal flexion, might be okay. Again, not ideal. And exercises in water, it's better than swimming because there's a little bit more loading, but I think land-based is still better. The muscles in the back, we haven't really gone over, but you have the erector spinae, those long ones, are the extensors. And the origin is the massive musculotendinous bulk over the upper sacral and lower lumbar vertebrae. They resist gravity during erect posture. And then you've got your abdominal muscles in the front. They're flexors and rotators. They don't have any spinal attachment, but they do also, some of them, especially the transversus abdominis, will attach back there to promote extension. And when they are firing, the abdominals will increase intradiscal pressure substantially. There's actually a lot to talk about in this slide. We want to decrease flexion and promote extension. So I think it's important to remember that, the spine is basically the vertebrae stacked on top of each other with discs in between them. But behind are the facet joints. So the pedicles and the facet joints. So the pedicle facet complex normally bears about 20% of the intervertebral load. The remaining 80% is absorbed by the intervertebral disc. So adjacent vertebral bodies and the intervertebral discs between them, they form the shock absorbing units of the spine. But with increasing age, the resilience of these intervertebral discs decreases. Therefore, the increased compressive forces on the spine then become transferred directly to the porous vertebral bodies during flexion of the spine, whereas the posterior segment protects the neural structures and directs movement of the units in flexion and extension. The intradiscal pressure at various positions of the spine has been measured at the L3 level. The highest compressive forces on the spine are during lumbar flexion and sitting, and they decrease with standing. The lowest intradiscal pressure is in the supine position, obviously because you're unweighted axially. Functional spinal units permit more natural flexibility at the lumbar and, to a lesser degree, lower thoracic spine. Therefore, it's not surprising a considerable number of vertebral fractures occur in the mid-thoracic spine, where flexibility is not present and gravity forces are maximal because of anatomical kyphosis and increased forces at the thoracic concavity. One study of comparable groups of women with osteoporosis showed that 89% of the subjects who performed spinal flexion and bending exercises increased the number of their vertebral compression fractures. So if you're doing a flexion-based program, you're actually increasing the chances of these women getting compression fractures. Among the women who performed no exercises but mainly applied heat and massage, more compression fractures developed in 67% of the subjects. However, only 16% of the group that performed back extension exercises developed further compression fractures. Therefore, the results of this and other controlled trials substantiate the importance of back extensor strengthening exercises for reducing the risk of vertebral fractures, whether for prevention or for treatment. And clearly, people with osteoporosis or a fragile skeleton should avoid spinal flexion exercises and loading of the spine in a flexed posture. So, back extensor strengthening, as I just talked about, has shown to be less osteoporotic than normal women. The mechanism by which it does this is not totally understood. But here's a 10-year controlled randomized follow-up study of estrogen-deficient women, and the relative risk of compression fracture was 2.7 times greater in the control than in the ones that they did a back extension strengthening program. So the back strength was measured every 4 weeks, and the program was basically specific progressive resistive weightlifting to strengthen their back extensor muscles with a calculated safe amount of weight, which was 30% of their maximal weight lifted. So not that much. And after 2 years of progressive resistive exercises for back extensors, the exercise group stopped the prescribed exercises. So 3 years after starting, they stopped the exercises. They kept increasing back extension strength. And what ended up happening was that at 8-year follow-up, that group still significantly was stronger than the control and had insignificant less loss of height, but still less loss of height. So the benefit, the dose they took maintained benefit even if it didn't keep increasing. So one caveat, if someone does start a back extension strengthening program, it may unmask or worsen spinal stenosis symptoms or arthritis of the facet joints, and a neutral spine stabilization program of abdominal isometrics might be more helpful in this population. Since this is a multifactorial condition, I think it's important to consult with your peers on the things that you're not as strong with. So I don't manage the medications. So either their primary or an endocrinologist should be involved. Psychological issues that come from loss of function and progressive decline in daily activities definitely has to be addressed. It's an adjustment disorder. Nutrition, maybe you're good at it, maybe you're not. and definitely involve a spine surgeon when dealing with an unstable spine or trying to directly address the deformity. So there's three different things that can be done. One is kyphoplasty, another is vertebroplasty, and then any other kind of surgeries that are needed if there is some cord compression involved. So vertebroplasty is basically sticking a needle into the vertebral body and injecting acrylic cement into the collapsed vertebra to stabilize and strengthen the fracture in vertebral body. It doesn't restore shape or height of the compressed vertebra. Kyphoplasty is where cement is injected into the cavity created by a high pressure balloon. And so what it's trying to do is expand that in restoring the height. You can dive deep into the literature. This vertebroplasty has been around longer. It's generally considered safer. But kyphoplasty is the more ambitious one to try and restore height. I haven't looked at the literature for this since 2006. I think it's important to know that there are, since we're not the only ones treating this, I think it's important for you to know what primary care is thinking. In 2006, these were the guidelines and recommendations from a consensus panel. You should know what the surgical guidelines are. You should know whether it's orthopedic or neurosurgical spine. You should know the endocrine guidelines, and so that you're a member of the team that's taking care of these patients. If you're someone who's going into spine treatment, I think this is something where you can really offer a lot of benefit, and it's not through procedures necessarily. So I'm going to end with a quote from Sinaki. She says, "Kyphotic posture and vertebral fracture are no longer disorders about which nothing can be done. The role of muscle strength in the maintenance of musculoskeletal health has not received adequate attention, and therapeutic exercise plays a substantial role in the management of post-fracture spinal pain and in the prevention of fracture." Those are kind of the overall themes here, and I hope that this has offered some insight and a start to your studying for osteoporotic compression fractures and osteoporosis in general. Yeah, that's it. Thank you.